That's okay, we can move it. It's easy to just look at the numbers, but if we all think about what we were doing 26 years ago and how much life we've all lived in the last 26 years, that's a difference between grandchildren and great-grandchildren. It is so much life and living, and it's not okay. I think, and I know everybody in this room believes that, it's not okay. These gaps do not have to be this way. And we want to be part of the solution as an organization, as a partner in this community. And one of the things that I think is always, many of you in the room may know this, one of the mindset shifts, a lot of people think that your health outcomes, your life expectancy, your survival is driven in a large share by your access to healthcare and the individual choices you're making. And the reality is 20% is driven by healthcare access and quality. 80% is driven by these other factors of the environments and conditions in which we live. We're driven by economic stability in your family, the education access and quality, your social and community context, your neighborhood and your built environment. And so these disparities matters a ton in driving the outcomes and the differences in life expectancy that we see. And I'm sure this is not surprising, but just looking at what are those differences in the characteristics between the neighborhoods and census tracts that have the highest life expectancy and the lowest. And you can see some of the data laid out here on the bottom in terms of those with lower life expectancy. They're younger. They have a higher percent of those who are Black and Hispanic. They have less income. A much higher percent are renting their homes. So 56%, over half, are renting homes, as opposed to about 1/5 in those that have higher life expectancy. And about 1 in 5 don't have a vehicle in the house in those census tracts with lower life expectancy. And this is a graphic that I think many folks may be familiar with. I was less familiar with the far right panel, and I just want to talk a little bit about this because this is kind of a journey we've been on as a country, as a community, about what do we stand for. And I think, for a long time, we've been in this third panel of equity, which I think we have made progress on, that people situated differently need different supports. So those that are more disadvantaged, your smallest kid on the right here, needs more boxes to stand on to see. But is our role as partners in this community or as a foundation to constantly be redistributing to give more to those that are further behind? And yes, that is important. But where we really want to move towards is to this far right panel, where we don't have systems that are creating such unequal outcomes, right? How can we not just fix the solution in the moment, but how do we, over the long term, remove barriers and policies that are preventing everybody from accessing this baseball game? And you're addressing those underlying causes of the inequity. And this is my last slide that has a lot going on it, but I just this tree is something we talk about a lot as an organization. The top is disparities in health outcomes that occur. And the roots below the surface there are the social drivers of health and well-being that lead to some of those disparities. So at the top, you can see there's all sorts, the differences in cancer survival rates, the differences in COVID survival rates that Steve talked about. The difference in incarceration, diabetes, all these different outcomes where we have disparities. But what's underlying those is some of those broader social drivers of health that we talked about: economic stability, education and access, healthcare access, housing, access to affordable, stable housing, social isolation. And then the other big piece in here that I want to draw attention to is racism and discrimination. That is a huge factor. And it is one of the big things that we talk about internally in disparities. There's this sense that, and it's in the popular press all the time, that race drives differences in outcome. It is racism. There is no difference in the internal workings of a Black body versus a white body, right? I just saw last week, there was a big article saying they were studying thousands of individuals in brain deterioration and dementia over time. And one of the conclusions was Black brains are aging faster. And then if you go and read and you go to the source article underneath it, it's actually that the stress of racism and those who are Black experience is causing their brains to age faster. It is not because of their skin color. And this is a belief that is inculcated in so many aspects of our medical system. And just understanding that racism, not race, is what is driving some of these disparities is a really important thing that all of us, just in our everyday life, when you see an article, when you're talking to folks about it, we need to call it out, unpack it. I mean, even there's an amazing professor at University of Pennsylvania who came and presented at the YWCA breakfast a couple months ago about this very topic, and how even in like some of the screening for kidney function and other things, there's different cutoffs for different races, which are not proven, and we shouldn't have them in there. And so just having that framework, it's something it's been normalized in a way that we all can make a difference in calling this out and pushing for changes around that. On the right side here, when Brian was doing my introduction, he was talking about some of the areas we've been focused on in the past 5 years. Since I joined in January, we've been going through our next 5-year strategic plan. And these are the 3 main areas that we're going to be focused on. Overall, we focus on health equity and health justice, and how do we add life to years and years to life. So we want to increase overall life expectancy. As a region, we are 2 years below the national average in terms of life expectancy, and it's been that way for a long time. And those gaps of 26 years, those haven't been closing. So that's what animates us. That's what we're about. The 3 areas that we're really going to focus on over the next 5 years is improving mental health and well-being, particularly among youth. This is it's a crisis nationally and locally, and we want to help bring mental health out of the shadows. And how do we strengthen mental health services and prevention in this region? We want to, in the second area, is really focus on those communities that are furthest behind, those neighborhoods and places. And how do we go into those communities, not saying, this is the program that you need in this community, but how do we give them resources to support what they see as the needs in their community and build the leadership capacity in those communities. And then the third area is really going to root causes. How do we change policies and systems that are leading to some of these inequities? We do not want to just keep mopping up the floor or providing crates like in that graphic. We want to get to the root cause of some of these issues, and how do we make long-term system improvements? So this is not easy, I would say, and that's why I'm here today. Like, it takes all of us. It's not about one sector. Foundations can't do it. Nonprofits can't do it alone. Churches can't do it alone. Government, businesses, it takes all of us. And the last thing I'll close on, and what keeps me up at night, honestly, is I think we are at a particular point in our country, in our diet, there is so much divisiveness in our community right now. And I saw this, many of you may know, I ran for office in 2020. It was the last time I was in this room. I came for a candidate forum. And I talked to thousands and thousands of people when I ran. And the reality is most people are not that different. It was really reassuring. Most people are 60-40 on most issues. And yet you go onto on social media, or you read journalism, like the revenue models of those, so the algorithms on social media and the way our journalism revenue model is based on conflict. And so there is this very real perception that we are further apart than we are. And that makes it difficult to come together and solve these common challenges, these massive challenges that are going to take all of us. And so that is one of the things that I think about all the time, is how do we, with our churches, with our nonprofit organizations, with government, like how can we all be a voice to bring us together to not buy into this narrative that we're so divided? Because in our individual lives, and this got worse during COVID when everybody was online more because we didn't have as much interaction together. But I think we have, in this community in particular in Cincinnati, we have the ability, we have the relationships to come together and really find ways to solve these complex problems together. So I will end on that. I'm going to stop sharing because I know there's so much more richness in the discussion than in having slides up, but I wanted to just share a little bit of that context before we go have more of a discussion. I did.
You're brilliant.
I mean, with my team, sorry, I'm not, but yeah.
The kids watching the ball game,
Yeah.
that's great.
Yeah. No, thank you. I think that is, and and we can share these slides. There is, we did not do that graphic. There is a source on there, but we've been using that to talk about it because it's a good way to get to the point we all know, which is we've got to get to the root causes of these problems if we want to fix them long term. Yes.
First of all, I have a positive comment that really appreciate that you all have looked at your goals and, and are allowing more to come up from the bottom rather than coming down from the top. The alcoholism, I'm sorry, the smoking, other things that are behavioral, imply a certain amount of judgment by us against them. And so it's really exciting. I'm excited about your new priorities. And also wanted to just thank the foundation for, I'm with the Urban Appalachian Community Coalition, and you all have been an important part of helping us document health disparities in the Appalachian. Keeping in touch with your research directly. Just, I'm celebrating the fact that you all have taken a new set of priorities that will, I think, allow, like, you helped create us with one of your grant programs.
Yes, back in the, yeah. No, the commitment to rural is really important, and there are many fewer foundations available to, as you know, support rural needs. And I definitely thank you for the feedback. I think we started this whole strategy process by just listening, and hearing that it's both being, let priorities be driven by those closest to the problem, know the solutions, but then also not be so narrow that people have to twist themselves into a pretzel to make something fit, right? I am particularly, so our commitment to rural remains very strong. I think it is interesting to me from a policy perspective. I think there's actually a lot of opportunity around rural and urban high need areas that have been left out, that haven't had their equitable share of investment in areas. And those can be really powerful coalitions when you are trying to change policy. Is going together. I mean, there was just an example in Texas where they have changed the whole way education is funded in Texas. And it was a coalition of rural and urban poor districts that came together, and it blew the legislature, very far right legislature. But they changed the way they did this because I think there's power there in bringing those needs together are similar. It's communities that need more investment that haven't had their fair share of investment, and going in a united way. I'm really excited about how can we bring coalitions together to tackle some of these issues. Yeah.
Thank you for that presentation. Just by way of introduction, my name is Shaunak. I am an associate professor of health communication at UC. But I'm here really, I work with Steve at the Cancer Justice Network. The academic part of the academic community partnership that we've had for a year now. So I'm really energized by the sort of social determinants of health approach that clearly sort of seeks through the strategic mission of the organization. One of the things that we have struggled with at Cancer Justice Network is both the recognition that a lot of the cancer disparity and the difference in outcomes stem from these systemic root causes. And yet, healthcare is just so instrumental in the everyday experience of community members, right? And so in some ways, healthcare is that, and this is a terrible analogy, but healthcare is that gateway drug towards health, right? We kind of have to talk about how do we have a just experience at the hospital? How do you not feel disrespected or disregarded? Could you talk a little bit about how do we do the both and, right? Yes, towards justice, right? It's important for the wall to be taken out.
Yes.
But in meanwhile, those boxes do a critical kind of function, right?
Yes. Yeah.
And that's kind of been our challenge in saying, you know, how do we do both, right?
Yes.
Or how do what is that journey like? I would love your perspective.
Yeah, I think that the health.
Kate,
Sorry.
if you could summarize a little bit, it's not coming through for the participants. If you could just summarize just a little bit.
Rephrase that. Sorry.
That's okay. Everybody just asked
Did you,
questions. Just summarize.
I will do my best and you correct me.
Right.
So for those joining us online, the question was about working in the health, like at UC, and a big part of it is both the healthcare experience. There is the social determinants of health, but there is a very strong reality that folks have a different, Black and brown folks have a very different experience when they're interacting with healthcare. I have a couple thoughts on that. One is I think we need a more diverse health workforce. That is something that, because it is not representative of our community now, particularly among physicians. And that is something that I'm passionate about. It's not something that that is publicly shared right now across our health systems in the area. What are the percents diversity look like in our clinical workforce? Because it's not where it needs to be. But I think that's something like, let's be clear-eyed. Let's talk about what it is and where we're going. Because I do think that there's more empathy, there's more trust. I actually think even some low-hanging fruit that and I think this is really important in mental health care. Somebody who our LGBTQ community has some of the highest mental health rates. There should be an easy way to look up if I want a psychologist or a therapist who is a veteran, who is Black, who is LGBTQ, who shares how can we make easy ways for people to identify services with somebody that they really trust? As a woman, I prefer a female OBG, right? Those are our preferences, and we've got to, I think that is a big part of over the long run, how do we fix that? There's definitely more training that is needed around stigma and bias. I think the data is super interesting. Dorothy Roberts, this professor I mentioned earlier, and she's got a TED Talk, you can look it up. She was presenting on the breast cancer rates and how white women and Black women had the same survival rates all the way up and through the 80s. And then when some of the new therapies became available and improved diagnostics, there became this big gap. And it was because the white women had more access to them, right? So it's not just some of the underlying conditions that are leading to differences in incidence. It is, the access is a huge part of it, and we have to do both. Like you're saying, we can't do one without the other.
Thank you.
Yeah.
Is it possible to change the focus of hospitals from having to go to the hospital rather than to go to the community and say there can be community resources that are easier to access? The health department is one kind of step, but it's still a step that looks like a hospital. We're thinking about churches and synagogues and mosques as potential sites for diagnosis as well as for treatment. But the attitude of the hospital is this is where it takes place. It doesn't take place in the community. And we know from the work of Paul Farmer that it has to take place in the community if there's going to be a change. If we're not going to get rid of AIDS in Haiti, if people have to go to a hospital, or diabetes in Rwanda, if people have to go to a hospital, but we can go to the community with the community and make a difference. Do you see any glimmers of hope that there can be a community focus towards healthcare?
Yeah, I mean, I think, and I know you're passionate about community health workers, right? And more, I think we need to be creative as a community about what are those ways where we can engage community health workers. I think in the mental health space, there's a huge shortage now. I mean, we're having this youth mental health crisis, and the wait list for kids is over 3 months long just to see one. And we have a huge shortage in the behavioral health workforce too. Are there ways that we can train counselors, social workers, more lay folks with some of these skills that can engage in the community to help do more of the prevention, do more of the initial support to folks? Because, and then I do think engaging with the hospitals, they have to spend a certain amount of their community benefit dollars to support the community, right? I think there are ways, and this goes to organizations like all of us, how do we approach the hospitals to say, hey, we really want to, because they're incentivized now too, they're moving towards more, instead of fee for service, more, they have quality indicators that they have to meet. And there is an incentive for them too, to not have everybody showing up at the ER, right, for these visits, and to do better prevention. So if you went to the hospitals and say, okay, we have, a community, our plan to strengthen community healthcare is in these areas, could you each chip in a certain amount? I think we have to understand that the hospitals are very competitive with each other. So you kind of have to think about, how do we frame it to them all at once, because you have a public good problem, where if one hospital is going to invest a ton in community health workforce in this community, and the other hospitals will be like, great, we'll all benefit from that. So there's no incentive for an individual hospital to do it. You kind of have to say to them, okay, here are some of the big community strategies that we can do to improve prevention, to have more engagement at the community and through trusted relationships in the community, and how can they plug in a collective way so that it's not, so that you're understanding the reality of the dynamics between, I mean, the best thing would be to fix our national healthcare system, but
right.
That,
But even,
yeah, sorry.
but even with community engagement,
Yeah.
I had to take a client to a procedure yesterday, and he chose to go to Westchester because he thought that would probably be less crazy,
Yep.
less people, less, well, it turned out his surgery was like 2 hours behind because they got backed up. But I can't help but think, okay, so we do have hospitals spreading to communities, but when they spread to communities, they go to outer communities where there are basically, all white. They're all white communities. And so people of color cannot get out there.
Right.
So even though we have hospitals spreading to communities, how do we make them understand that spreading to white communities is not addressing the issues that we have? If that makes sense.
Yes, it's a hard, I mean, for those online that comment, what's your name? Pat was sharing that she took
I'm with Cancer Justice.
yeah, she's a navigator who took one of the patients out to Westchester yesterday for a procedure, and was just saying that even when hospitals are spreading to community, they're often spreading to wealthy white communities instead of communities here that are highest need. And I think that's a really acute need too in rural communities, because the rural hospitals are closing in many cases. And it was, I don't know what the answer is. When COVID, so during last year, I had a role based out of the Health Collaborative helping to coordinate vaccine rollout in this area. I was on a call at the beginning, it was every morning at 7:30 with one executive from each health system here. And then it became 3 days a week and eventually down to 1 day a week. But they shared, and this did not happen in other parts of the country, they shared their hospital capacity every morning for ICU, for their med surgical beds. and balanced capacity across who could take what patients. There were rural hospitals that were part of it too, when they were trying to get folks in. And it was the most collaboration that I have ever seen around the healthcare systems in this region. And the interesting thing is, we pulled the 2020 data, which is the most recent data. Our survival rate for, or our COVID death rate is lower here than in the nation. And in every other top 10 cause of death, COVID was, I think, 2 or 3 last year, or in 2020, we're higher than the nation for the death rate. COVID was the only one, but we were lower. And I think a part of it may be this level of coordination that happened. It's like, how do we use that for other areas? I don't know what the answer is yet, but it is a problem. It is, because we have to, this is the hospitals by definition are focused on, they have to run an effective operation, right? And their individual organization, but the overall health of the community and the healthier we all are also helps them as well. And so it's like, how do we solve these public good problems where it's in everybody's interest to improve the health of the community? But we've got to, I think we need to bring solutions to them that help guide them how they can plug in a way that's most meaningful, that isn't just, building, that's fine. Let them, more buildings in wealthier areas to have outpatient. Yes.
I'm Prince Brown. I attend Class 50 people. I'm a retired professor of sociology and African American studies. And I don't know how to say all that I want to say, but I'll try to be brief. I've been attending various presentations 50, 60 years
Yeah.
now. And what I hear in them is a grind. We're just talking about the same things again and again. And forgive me, and I don't want anybody to feel that I'm criticizing. I'm trying to explain something. I hope that's what I'm doing. And I'm particularly attracted to what you listed there as your second fourth focus, community empowerment, because I think that there are some things that we're wasting our time trying to change people's thinking. Okay, so when we talk about all of these healthcare delivery systems, we have to understand that they are intimately connected and tied to the overall economy of society. All right, and so when we begin to talk about helping the downtrodden and those who occupy the bottom rung of society, we have created a workforce to do that. We've created economic systems that pay people to deliver services to that so-called marginalized group. And to summarize quickly what I'm trying to, one would get at, why not invest the money we invest in paying a group of professionals to service those people in the people themselves?
Yes.
Okay.
Yes.
So, and I've had this argument throughout my academic career. But no movement in that direction. And please, I don't want anybody to misunderstand what I'm going to say next. But for years, I've been asking the question and pointing out that we invest millions of dollars in training social workers. Don't misunderstand me. They address a present critical need. I understand that. But why not again invest in empowering the communities to help themselves and represent themselves? Because as you said, they are closest to the problem and they know what the solutions are. They know what they need. They don't want to be told. A part of what the problem is a narrative from the larger community is we know better than you do what is best for you. Also, we think that you aren't capable of taking care of yourself, so let us, we want to take care of you. Well, for God's sake, I'm tired of all that goodness. So what we need to do is develop the genius and talent in the community. And I'm going to try to be brief. Just let me use one example here from Cincinnati, a hospital location, for example. About 4 or 5 years ago, a young woman who grew up in Lincoln Heights, poverty-ridden Black neighborhood in Cincinnati, ran for mayor. All right. And at the time, the Children's Hospital was trying to expand. And he had tried to speak to that expansion because the expansion was also displacing some poor people. And we know that whole housing thing, right? And so every powerful voice in the community, including the Inquirer and all the people who are supposed to know, jumped all over her because she demanded that in creating this new division of Children's Hospital, which nobody's going to argue about, that a specific focus should be given to the people being displaced, and that should be acknowledged. And somehow in the expansion, there is a provision in the planning that addressed that issue. In other words, Children's Hospital never said, okay, we know we're going to displace some people. One of the things we're going to do is to guarantee that every year going forward, from now on, a minimum of 10 to 15% of what we spend in the way of evolving will be directed at reducing health disparities in this community that we're displacing. People ignore all of that. All the, oh, you are against health, against healthcare. How can you argue against, you know, what these good people are doing to you? That's insulting to people of color to say that we aren't smart enough to understand and recognize the needs of healthcare. I hope I'm making sense to you. But what I'm trying to say is what is institutionalized is a belief system that people refuse to acknowledge, and that the very people we ask to serve the downtrodden benefit from the system being unequal. Okay? And you get into all kinds of arguments with people when you try to get them to acknowledge that. I don't want to speak forever. I just want to make one final comment. And again, I'm not criticizing. I understand the need for healthcare workers, social workers. But I'm saying we continue to lie to ourselves as a society. And as long as we continue to lie, then what we're talking about is going to continue. And, you know, African American and I think other academics of color, when we enter higher education institutions, we have to make a decision. The decision is, are we going to try to be an expert in our area of choosing for us to serve everybody, or had we better do something specifically to address the needs of disorganized and abused and marginalized so-called minority public? That's the decision that we have to make. All right. I made the decision that I would become an expert in race relations. And on this point, I don't defer to anybody. Okay. And what I'm saying is that when we look at this culture, when we look at the world today, not this culture, when we look at American politics today and the upheavals that are going on, we all, if we are honest, have to admit one thing, that the fundamental fact driving the growing apart of American society today is the factor that people call race. It's malicious, it's false, it has no scientific or biological validity, but you listen carefully. Some politicians don't even describe it. Listen to your last former president describing African American communities. Listen to him describing Native American communities. And look at certain political parties and how they operate. They never talk about these issues. I'm preaching. I'll quit now. But what I'm saying is this. I think that when you direct resources is into those communities, all right, put the hospitals there, build schools there, put economic engines there so that they can develop the power, you see, to compete against the entrenched system. Because that central element that's going to enable transformation, if it is ever to come about, is the equalization of social power in society. As long as these so-called marginalized communities are subjected to voter suppression, they're going to remain to experience the disparities that are now happening. I hope I'm clear. Forgive me for preaching, but this is my role in society. I have to be a provocateur. I have to disrupt the system. I have to tell a lot of people, even though they may not like it, your good intentions are not enough. Stop talking and do something. Thank you for listening.
Thank you. Sorry, you're.
We have a couple questions on chat. Thank you. And you should have been up there at the camera.
I know.
Talking. Did you want to summarize what Prince said?
Prince made incredible points about that it's not about top down and providing social services. It is about empowering those in community and directing resources to those in community. And I could not agree with you more. I think there's a lot of evidence of that. I was talking to the head of the Kaiser Family Foundations that they said they spent $1.5 billion over 10 years across 10 communities in California to figure out like, how do we build healthy communities? And the number one finding was engage participatory democracy. How do you build the engagement and the resources of those in these communities? And from my experience in global health, like there's a whole movement to give directly. Instead of having all these social services that go to communities and say, you know, you need a health clinic here, you need this here. If they gave money to the women, there was such greater gains are made and people make the best decisions. They know what is needed. So I agree with Prince and what you're saying that that needs to be top of mind as we have got to be able to change the power dynamics. It's both resources and power to be able to change the systems.
We have a couple questions in chat. Do you want to look at them or do you want me to?
If you want to read them.
Okay.
Yeah,
you might have trouble. There's one that was way up. Invest in Neighborhoods is planning next March's Neighborhood Summit. The theme is defining healthy neighborhoods, measuring what, say the top 10 measures, and how that data and those priorities can help organize the focus of government agencies, NGOs, and others. Would you be interested in participating and planning the March 10th, 11th summit?
I'd be happy to have a follow-up conversation about how we can help with that. I think, is this the city summit with the 52 neighborhoods? Yeah, because I think there is, just had a conversation this morning. There's some really interesting stuff around city health, which is like, what are the most impactful policies across the country? And there's a recommended policy package. And one of them that there's a number of things we can do in the city here and in looking at neighborhoods and what are the needs in various cities. So I'd be happy to have a follow-up conversation. Yeah.
Okay, the next one is up there, I think. What involvement?
What involvement do you see for medical legal partnership and advancing institute? Yes. Asking on behalf of Legal Aid Society. Yes. I think there's a lot of opportunity. And I think many folks in this room are probably aware of with Children's, there was the Children's Hospital, very successful medical legal aid partnership. I think that is a big part of giving voice is having legal representation. One of the policies that is most impactful that I am super excited. I know Mayor Purval made an announcement about some of their efforts to address this is the legal right to counsel for renters prior to eviction. There's about 20 cities nationally that have passed a right to counsel that you cannot evict someone without they have right to counsel before someone is evicted. Currently, 3% of eviction cases where the renters have legal representation, and that goes up north of 80% when this policy is in place. Now, it requires a partnership with legal aid and funding to make that possible, but it brings down eviction rates tremendously. And if we think about some of those social drivers that lead to instability for children, in schools, for jobs, I mean, how traumatic and destabilizing that is. If we can go upstream and reduce evictions, that's a big opportunity. So that's just one example, but I definitely think there is a lot of opportunity in legal partnerships, not just in the medical space. Yeah.
My name is Tom Shuck. I'm a local attorney. And I worship here at Christ Church. But I have a lot of experience in Claremont County, southeastern.
Okay.
Claremont.
Yeah.
and I went through the LEAD program there a number of years ago. Let me suggest that in the rural aspects of the area you serve, the number one issue of access is transportation. Not just healthcare, but also life safety, police, et cetera, domestic abuse, all those issues. And I know that Cancer Justice Network focuses on providing transportation because the services are like pods or silos, if you will. You have to get to the silos. How can this transportation issue be addressed in your opinion?
Yeah, it's a great question. So for those online, we got a question about transportation in rural areas, particularly in Southern Claremont County. And it's not just for medical needs, it's for overall needs. And it is the number one issue that underlies everything. I don't know what the answer is. It is an issue. I think we've got to start by elevating it and acknowledging it. And it also goes to, that's also like with our approach, it's so true with the rural areas. It's not about, school-based health centers are hugely impactful. It's one thing we've done for the last 25 years, but instead of going to a community and saying your solution is a school-based health center, it is, we want to listen to the community and say, hey, what is it? And in the rural communities, a lot of it is going to be around transportation. I think the challenge is figuring out what do those solutions look like. Let's look nationally, like what are the rural communities that have figured out, is there a way to pay others in the community to offer rides to others? And, those who are retired, but still have access to a car, what are some creative solutions that we can find and learn from other communities? But I do think the more we listen in the rural communities, that pops up again and again as the number one issue.
I would suggest to you that insofar as public dollars are provided to hospitals like Brown County, Claremont Mercy, et cetera, to provide services, a certain amount of that money ought to be earmarked for transportation. And if it costs the hospital money or patients to get folks to treat, they'd be happy to go and get folks to treat, in my opinion.
It's a good suggestion. Yeah.
We haven't found that to be the case. We haven't found hospitals willing to pay for transportation. But we are committed to working with Metro here in Cincinnati to figure out a method where not rural, but urban access can take place, where public transportation can take people either at no cost or low cost to hospitals.
Right.
The number of people who can't get to Children's Hospital or University Hospital because they can't afford the fare is just spectacular.
Right.
And we have a budget, thankfully you've also helped us with that, that just is infinite in terms of the need that we have.
Yeah.
I'm sorry, Robert, go ahead.
No, I don't want to interrupt you. I want to boost you because I'm part of the Cancer Justice Network as well. And I'm also one of the pastors at People's Church. And one of our focuses is working with Cancer Justice Network. And I'm also the Schroder board. And one of our purposes is simply to provide transportation to all people, to understand that we need a better system to move people around, to get people to where they need to be and where they want to be, and for health services and for all of just life services.
Yes.
And you know that really well, I know. And I'm just proud to be part of this group and part of this group here today. And we really, one of the things that we really need to do is to get with the mayor, get with City Hall, get with the county commissioners, because the county has the power, and I'm glad that we managed to pass, 7, which gives us 25 years, or 24 now, to make this really work, and we can do that. And I'm just happy and proud to be part of all of you folks that are here today. And some of this has been going along for a long time. And we have to go back to, and I don't even want to spend the time talking about the fact that the transportation system is not real in terms of why it is the way it is. It does deal with race. It does deal with ethnicity. It definitely deals with poverty, and it definitely deals with my friend here dealing with the Appalachian. You know, and denial that the Appalachian community is strong. And one of the things that we get denied is that the Appalachian community is also integrated. There are Black Appalachians. People don't acknowledge it, but you know, we've been knowing that for what, 50 years, 40 years, you know, or longer. And we just need to say, time is now to take action. It's good to talk about it. It's good that we are passionate about it, but now let us band together, take action, and change it, because we have the power to change it. Do we have the courage to exert that power? And I know that, you know, like we've got the courage to do it. And so I'm done talking. Just let me know which way you want me to march, because you know, I don't mind marching. I don't mind holding my banners. I can wheel this wheelchair everywhere and anywhere. So thank you for the opportunity. And you keep on doing what you're doing, and don't be afraid, because that is what the system wants us to do, is to be afraid and go away. Thank you.
Robert, thank you for the lead-in for our next forum. 2 weeks from now, we'll be back here in live, in person and on Zoom, to hear from the Cancer Justice Network about things which are being done, which are making a difference, and on openings that we can look towards for more and additional things. So thank you very much. And thank you to Kate for her presentation today.